All right, let's get the event started here. Welcome everybody to the Hopkins Bloomberg Center. This special event that we'll hear about shortly is hosted by the Hopkins Business of Health Initiative. I'm Dan Polsky, Director of the Hopkins Business of Health Initiative and Bloomberg Distinguished Professor. Let me just say a couple words about this initiative and this special space. So the initiative, our goal is to unite the scholars across the university who share a vision of improving the U.S. healthcare system, make it more affordable, more equitable, and make it function better. And our special focus at HBHI is the role of business and incentives in moving towards or potentially making it more difficult to move towards that vision. And we bring knowledge to the conversation. You're here in this beautiful Hopkins Bloomberg Center, which on the website is what it says is, it brings together the brightest minds in policy, business, academics, and nonprofits to find solutions to global challenges for human advancement. Quite a lofty goal, and our goal at HBHI is to bring together a community of healthcare scholars in various domains across the DC community and build community to do exactly that in this topical area. So with that, I'd like to introduce the moderator for today's event, Melinda Bunton. Melinda Bunton is Bloomberg Distinguished Professor of Health Policy and Economics, and she has a very distinguished career as a national leader in healthcare policy. In the policy space, she has had director positions at ONC and CBO. In academics, she was founding chair at the Vanderbilt Department of Health Policy. And in publishing, she's a deputy editor at JAMA Health Forum. So you might see her name when you submit your stuff there. And she's been at Hopkins for a year now, and she's founding a center called Health Systems and Policy Modeling. Something, I might have missed that a little bit, some health systems and policy modeling, whew. And she is also has a leadership role at LDI as Director of Policy. With that, I'll turn it over to Melinda.
Thank you, Dan. So thank you all for coming out to this panel on cultivating trust in America's health system. We were really gratified by the response to this panel. It felt like everyone saw the announcement, decided it was back to school week, and we are delighted that Hopkins is your educational institution of choice. I've had the privilege of having discussions on this topic with our panelists in preparation for this discussion in front of all of you. And you are in for a treat. Each of them has a unique perspective on this issue that you'll get to hear about today. Just one housekeeping note, which is that we will be doing questions via the note card method. There are note cards at each row of the chairs. If you would like to pose a question, please write it on the note card, and members of the team will be around to collect those and hand them to me towards the end of the session. But with that, I will introduce our distinguished panel. First, of course, our elected official, Senator Richard Burr. He was senator from North Carolina from 2005 to 2023, and he is now Principal Policy Advisor and Chair of DLA Piper's Health Policy Strategic Consulting Service. And I don't think that's my microphone. That's a terrible noise. I apologize to all of you. I'm looking to the back. Okay. Next to Senator Burr is Dr. Lauren Taylor, an assistant professor in the Department of Population Health at NYU Grossman School of Medicine, and she has joint appointments in healthcare delivery sciences and medical ethics. And next to her is our very own Dr. Michael Darden, who's an associate professor at the Carey School of Business, and he is the academic program director for the Master of Science in Healthcare Management at Carey. So if there's any prospective students or mentors of prospective students in the audience, please see Michael after, during the reception hour. So I will start by posing my first question to Senator Burr. And when we were speaking before this panel, you emphasized the need to earn trust at both the provider level and the system level. And I hoped you could start by telling me your thoughts about that.
Well, Melinda, let me say thank you for the invitation. It's good to be here with Lauren and Michael, a good North Carolinian over here. How could you leave Nashville? I want to know that.
For the reception.
I'm a unique individual because I never envisioned doing healthcare policy. But when I got to Washington 30 years ago and I look back, I realized that healthcare was the largest employer in the congressional district in North Carolina. And when I got to the United States Senate, I realized that North Carolina was a microcosm of every type of healthcare you could find in America. So I was destined to address it from a policy standpoint. And why trust was something that you and I talked about was, as I have shifted now in age, not just from the Senate to the private sector, I shifted in age to a time where seniors are looked at a little bit differently. And I realized that my contemporaries, as I talked to them, they really were bewildered about who they should go to. And it concerned them because clearly they didn't feel that they were getting the value that in this case the federal government was paying for. In most cases it wasn't them. And it made me then question, how do you gauge trust? What is the definition of trust? And I think to some it's access to healthcare, to some it's the cost, and to others it's the value. It's what you feel you got. Ultimately, I think trust is you go to somebody who you feel is empathetic with why you're there. And not being a physician, I can only tell you that those visits have become so impersonal that it's really, really tough then for an individual to feel like there's somebody on the other side that's empathetic of the problem they deal with. And why I think it's so important right now is as we see technology play a bigger and bigger role in the healthcare space, and I might say that the COVID vaccine was a great example of this. Because of legislation that we wrote in Congress, not for COVID, but in 2004 we wrote it for, we did it for, sorry, I'm having a senior moment already. We did it for H1N1 threat that was coming up. That was actually the architecture that we created a vaccine and approved a vaccine in 12 months. And what was a lot of the public's reaction? I don't trust this, it happened too quickly. We're driven by what we historically perceive the pillars of trust to be. And what I see looking out the next 5 and 10 years, those are going to be totally broken away. And every one of us is going to be forced to determine what trust is using a different metrics. And I think we all agree, we talked before we came out, eventually it all has to coalesce around one thing. And it may differ between individuals, but there has to be a common thread.
So picking up on that idea of what is trust, Lauren, one of the distinctions you made during our conversation that I thought was so insightful was there's a difference between being trusted and being trustworthy. And can you tell us more about that and what it means in particular in the healthcare arena?
I can try. So yeah, this is something that I have become sort of obsessed with in my research, is trying to disentangle the idea of trust from trustworthiness, because I think they get conflated and they lead us to kind of oversimplify the problem. So when I think about trust, I think about a willingness to be vulnerable at the risk of exploitation. And it's usually a behavior, it could be a belief, but it's generally a verb. To trust is a verb. Whereas trustworthiness is a characteristic or an attribute. And the way that I think about trustworthiness is it's not just the attribute of being trusted, it's the attribute of being deserving of trust. So while trust can be studied empirically, almost every assessment of trustworthiness, I think, is inherently normative, meaning we have to make an evaluative or a judgment call on whether person X or person Y is trustworthy. What disentangling the two concepts does for us is it allows us to think about different kind of quote-unquote trust problems. So if you think with me about sort of a 2x2 matrix, we could have trust and don't trust, and then we could have trustworthy and don't trustworthy. Generally, when people trust trustworthy actors, we don't think there's a problem. But when we think they're trusting untrustworthy actors, we say like, oh, that's sort of a disinformation or a misinformation problem. We need to do something about that from a policy or other standpoint. Similarly, when people don't trust untrustworthy actors, fine. But when they don't trust people we do think are trustworthy, that's a different kind of potential policy problem related to trust. And I think only if you do that kind of minutia, and some people might think it's just like semantic or rhetorical work to disentangle these ideas of trust and trustworthiness, can you see those as two really different problems.
Thanks. So, Michael, you are a health economist who's studied trust in that framework of how trust affects care-seeking behavior. Can you tell us about your research?
Sure, yeah. Thanks so much for having me, and thanks everybody for coming. With support from the Hopkins Business of Health Initiative, my colleague Mario, maybe it was me. My colleague Mario Matchis and I have undertaken a research agenda in the economics of trust and care.
We're all looking at our microphones, except for Senator, who's very experienced and just sits perfectly still to show it's not him.
I'll just hold it. And care-seeking behaviors, so like the extent to which people are willing to seek out primary care.
Turn this one off.
Yeah.
Okay.
How's that?
Great.
Okay. So we've undertaken this economic research agenda on trust and care-seeking behaviors. And one of the main findings, one of the big findings, is that trust is just as important, variation in trust is just as important in explaining whether or not somebody gets a flu shot, whether or not somebody goes for a COVID vaccine, whether or not they go for primary care, as things that we know are important, like education and income. So, for example, college graduates are 40% more likely than high school dropouts to have gotten a flu shot in the last year, but that's the same proportion for high trust versus low trust. So it's clearly important. Trust is very important. But another finding, and this picks up at what Senator Burr said, another finding that we've come across is that it's increasingly difficult to build trust in a very complex system. And so if you think back in the 1960s when Ken Arrow was writing about these issues in the American Economic Review, most physician-patient interactions were a patient visiting a sole provider. They had repeated interactions with that person. And despite the fact that medical technology was relatively limited compared to today, those repeated interactions were an opportunity to build trust. And contrast that to today, where a patient visits a physician, that physician's part of a group. The patient is lucky to see that provider again. They probably see different physicians within the group. The group is owned by an umbrella organization that might have different incentives, a hospital system or a private equity firm. The pharmaceutical that was prescribed was recommended by the CDC and approved by the FDA, which are both greatly distrusted within certain segments of the population. And so it's just a much more complicated system. And so paradoxically, despite the fact that medical science is so much better, we have a system that makes it difficult to trust. And I think that picks up nicely with what they've said.
Well, and that also leads right into my next question. Given that this is a Hopkins Business of Health Initiative event, and we, as you've just said, we know that current business models, which create financial incentives around volume, around billing issues, how do those things align with trust? And can you think of ways that we could better align business models with building trust? Anyone can start. Anyone to
Let
start?
me just jump right in. Transparency.
Transparency.
I mean, the American public has no idea of what the cost of a visit's going to be. And it's hard to assess value if in fact you don't know what the visit cost. It's amazing the discrepancies between what insurance pays and is charged and what you would pay out of pocket if in fact you negotiated the visit. So there's every reason for people to be concerned about a system that really is bifurcated in the way it operates. And I think Michael brings the economics into it, which makes it even more confusing because you really don't know what the driving force is behind either the practice. We all like to think that when we see that doctor one-on-one, they're there to take care of us. They're there to diagnose us. They're there to take a person that's sick and get them well, or to take a person that's well and keep them well. I don't think many Americans question that. It's after that that the real question mark comes in about motivation.
Yeah, I'll follow up on that. I mean, I think financial incentives and financial motivations have always existed in medical care. This is not something that's new. I think what has changed dramatically are the rules of the game in which these physicians operate. And so if you think to a fee-for-service kind of system, right? The incentives are for more utilization, for more care, and to a large extent, that we're concerned about overutilization. But patients kind of like more care, right? I like the fact that I'm being offered the fanciest technology, and so those incentives, in a sense, kind of align with the patient welfare. Putting aside issues of whether or not these extra services are actually productive for health. But now we have a system where in prospective payment, the incentives are exactly the opposite. A provider wants to get patients out as quickly as possible. And that's so much so that in the Affordable Care Act, they put in readmission, penalties for providers who were getting rid of patients so quickly that they would reappear in the system within, a certain period of time. So I don't necessarily think that doctors or hospital administrators have become more greedy. I think it's that the rules of the game have changed so dramatically in ways that make it more difficult to establish trust, fewer interactions, and incentives that don't align with what patients want.
I hate to disagree with the senator, but I'm not as optimistic about transparency. I think many times we have done the same refrain in health policy and said, if we could just show people what it would cost, we would let them comparison shop. People would go and be very forward thinking about where they would want to get their care, and this would drive down the total cost of care. And it just hasn't worked. People aren't as rational consumers as we want them to be. And I think if we're just talking transparency, like show the prices, it's not going to be simple enough. If we're thinking transparency, like radically simplify and then be transparent about how costs get arrived at in U.S. healthcare, maybe, but then that feels like a much larger intervention than just transparency. It's real, like, overhaul of payment schemes again.
Okay. Do you want to follow up on that, Michael?
I mean, I would just say with transparency, I think that kind of being transparent, we could maybe learn from other sectors. So in the financial services industry, right, they spend millions of dollars putting out ads that say, we make money when you earn money. Right, so they're trying to demonstrate that the incentives are aligned in some way. I think it's more complicated in healthcare. It's hard to say, we're going to be reimbursed when your health improves, because risk adjustment isn't perfect, and understanding the counterfactuals is really hard in health. So.
But let me tell you, that might come into play in the future, because when we look at cell and gene therapy as an example, and you talk about curing a terminal problem, but the cost of it is $2 million. It can get approved, but then all of a sudden you hit this reimbursement wall. And what we've seen is we've seen a reluctance on Capitol Hill, a reluctance in the country to start the debate on how do we pay for that. We all agree that if you identify somebody that has sickle cell anemia, especially a young person, curing them is a tremendous savings and it's a change of life for them. But we've got to have a national debate about how you pay for something like that. And at the end of the day, it may be that part of it's the federal government, part of it's an insurer, part of it may be the innovator of the therapy, and part of it may be the individual patient. So I think that we're going to see as we get more technical and more expensive on some of the technologies in healthcare, that innovators are going to be pulled into this in a way that there may even be guarantees, Michael, where if you have this procedure, if you take this therapy, and 20 years from now, it's reversed, then all of a sudden the innovator is liable to go in and cover it. I think we're going to look at all sorts of different approaches because the way forward is that expensive, and transparency won't be a mandated thing. It'll be a requirement by the consumer then.
So let's dig into this a little bit more because there's so many layers. And my next question was about transparency. So we've got time to talk about all of these things at once. So if we had better transparency so that people weren't afraid of what visiting the doctor might mean in terms of cost, if we had more radical transparency of the type that Michael was pointing out about incentives in the system, if we had incentives aligned so that people could trust that doctors' goal was to help them get healthy, that they weren't worried about doctors profiting from them being more ill or from things that wouldn't actually advance their health. And then, Lauren, you're talking about a more evolved discussion of what the healthcare system is supposed to look like. How do we get there? Do we start by talking about things that are so expensive that people feel that the system is is untrustworthy because it's become unaffordable? Or would you start with something more simple, like talking about trusting primary care?
I have two quick thoughts, maybe. One in the kind of arc of what you described, which inevitably would require a pretty extensive policy revision and then a pretty complicated, unavoidably complicated policy framework. We should just be aware that even if we quote unquote got that right, like among the wonks, and we were like, oh, beautiful, it's going to be complicated, and certain people read the complexity of policy as inherently distrustful. And so like we're kind of right back in a challenge there. So the other thing we haven't talked about here is, one, healthcare is super complicated. It's always going to be complicated, because think about, even if I were to go to the doctor and say I want my price ex ante, they can't give it to me. They don't know what they're going to find. They don't know what kind of follow-up work they're going to need to do. So I think it's always a little bit of a fantasy to imagine that we can make it more simple than it is. It's just an open-ended affair, and it requires some degree of like true vulnerability, both with my body and my pocketbook, when I go and like enter into this kind of therapeutic relationship. So there's kind of two ways in my mind to try and shore that up. One is the policy framework, as I've talked about, as we've talked about, and that's like one set of patches you can put on something that's really complicated, and that, as Michael said, has always had some kind of inherent profit motive to it. You know, like the doctors of 100 years ago, yeah, they were good guys, but they too were trying to make a living and put food on the table for their family. So it's complicated. There's always an inherent profit motive. Policy is one way we kind of wrap that up and say, like, we can make this a trustworthy sector. If you think that policymakers are trying to correct for information asymmetries, require transparency in certain places, make sure there isn't monopolistic pricing going on. Those are all policy moves. The other one, and if we had a clinician here, I think this is where their brain would go first, is like, it's old school professionalism. The idea that there is a guild and that to be a doctor or to be a nurse or to be a social worker disallows certain kinds of behaviors, not because they're illegal, but because they're not professional or they're unethical, is the kind of second level of hemming in both the complexity and the profit motive. And I think while the profit motive maybe has always been there, there has been a diminishment in how much faith people put in like this good old Doctors Guild, Hippocratic Oath. And as that sort of wears away, I think at one point we were like, oh, that's like a nicety. That was a fantasy that we've let go of. But the result of letting that wear away is we're stuck in a trust problem that obviously has all these consequences, low vaccine uptake rates, et cetera, et cetera. So it's one of
Interesting that you mentioned 100 years ago. I mean, maybe you're calling for another Flexner report, like a new generation Flexner report, because that's when we had, that's when healthcare professionals became part of a much more explicit guild with much more explicit
and I think
rules.
it'll require going up a level of analysis, right? Because the Flexner report was very much based on an idea of individual physicians.
Yes.
And you can see this, the ACGME, the American Academy or College of Graduate Medical Education, is starting to say, oh, we need to think about organizational professionalism. And I think it's right in this vein. It's saying we can no longer rely just on an individual level code of ethics for physicians or clinicians because they're increasingly employed, because we have so much market power concentrating. We have to think about these kind of ethical rules of the road at the organizational level.
So Lauren has pointed out how complex this is. Yes, healthcare is very complex. And then we can layer on top of that more complexity. So there are a couple of things I wanted to throw out and ask you three for your reactions to them and how it fits into this issue of building trust. One of them is the issue of medical debt, which I think relates to some of the things the senator mentioned. Another one is the issue that we have historically, the medical profession has wronged certain groups in our society who would understandably carry less trust in the health profession as a result, even generationally. So how do we bring those types of issues into this conversation?
I mean, I can speak to the medical debt. I mean, there's a fabulous new study from Neil Mahoney at Stanford in which they randomized medical debt relief. Mm-hmm. And they find some pretty sobering findings. So they find that people are in no better financial state, a year or two later after their financial debt relief. In fact, their mental health is worse from medical debt relief. I mean, I'm sympathetic to the idea that the financial implications of going to the doctor can be very, very important. And I think that actually dovetails nicely with some of the research that's going on in trust in the financial sector. Mm-hmm. So in that literature, the bigger the financial transaction that somebody is making, the more trust matters for whether or not they're going to go forward with it. And I think that offers a mechanism behind our results that, in our work is that trust really matters, particularly in this arena where things are very expensive. But I think the medical debt argument there, also the study that has come out with this randomized trial, also just emphasizes, that this is completely different than any other sector, because these people, because people when they go seek care, they really need it, and this is not like buying a house. It's very different.
In thinking about groups that have been historically discriminated against, the Institute for Healthcare Improvement has put out a nice kind of roadmap for rebuilding trust, and I would just pick up on one part of it, which is that the roadmap starts by saying, like, look, if you, healthcare administrator or leader, are really serious about trying to build or rebuild trust with a patient base or a community, it starts by acknowledging past breaches of trust. And that's really uncomfortable for a lot of managers and leaders to do, both because of like a culture of general liability avoidance, but often because people in leadership positions are now feeling like, oh, I have to apologize for something that maybe I didn't do. It happened 20, 50, 100 years ago. And yet, I think IHI is not alone in trying to spotlight the importance of acknowledging past breaches before you can start to kind of paper over and say like, oh, you should really trust me for this reason. You have to first kind of acknowledge historical legacies that maybe no one alive experienced directly, but that are carried intergenerationally in many cases.
Yeah. That's something I think you learn when you're associated with an academic institution like Hopkins or like I was at Vanderbilt. When you walk into a room, it's never just you, it's also the institution you're part of. Right. And understanding that.
And discrimination can be the result of access, lack of access.
Yes.
It can, well, just take COVID. It can be geographical. In the case of the criticism, rightful criticism on COVID vaccines, it was how you stand up a distribution network that is equal quickly. And what we found out that in that case, logistics was the number one problem. And when you recognize that there was a geographical discrepancy or that people were left out, then once you focused on it, you were able to fill the gap. And we don't have that today, and hopefully we won't have it going forward. But I think we underestimate the challenges we're going to have in the out years. And I don't want to shift it.
Say more about
but
that.
I think as technology plays a bigger role in driving where healthcare is going to go, it, one, increases choices. It, two, challenges us to accept technology's role that it plays. And clearly, I think the biggest technology is going to be AI. It's used today. It should be used next to a physician for some period of time until the trust is there in the system. It's in radiology today. It's in pathology today. I can envision in the next 5 years where AI will make a primary care determination next to a primary care doc. Because you're going to walk in as a sick patient and you're going to say, I've got this, 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 and this. And we're reliant on a doctor that's young enough that he still reads the Journal of Medicine, or that he's old enough that he's got the art of, I've seen this before. Now, if they happen to be somewhere in between, you're going to walk away and go, oh, I got the wrong person. But then when you lay this technology piece beside it, that's already programmed to say, if you've got this, this, and this, you need to test for that. What I think is that technology can be a huge driver in the definition of trust. But it doesn't instantaneously get there. There's an acceptance period that's got to be tried.
It can even increase distrust. But Michael, go ahead.
I think on the AI issue, it's very important to build systems around AI that make them complementary to physician labor. And so, I mean, there's good evidence now that, especially in radiology and imaging, AI is great as a diagnostic tool when the probability of a malignancy is close to 0 or close to 1, right? It's something that almost always gets it right. And so it doesn't have to be the case that we get rid of the radiologist or the imaging. We just take those people and we put them on the cases where AI says it's a 0.5, right? So now we've got 2 or 3, 4 docs who are looking at that image, which is very ambiguous. AI has not given us a real prediction. And if we build systems like that where there's complementarity between technology and people, that makes it more likely that we can trust, I think, what's going on.
Not to be the semantic nerd in the room, but I do think this is an example of where the term trust becomes used in such a way that it may not be helpful anymore. So when I say I trust a person, generally I'm making an inference about their trustworthiness. And I'm making an inference that we either have intersecting interests, like I trust the bus driver to come on time because he gets paid to do so. Or I'm making an inference about their sort of benevolence or altruism. That might be professionally motivated. I trust her because she's a doctor and that's what doctors do, or otherwise. Either way, I'm making a judgment about interests or some virtue, basically. And AI has neither of those things. And so the question is, like, should we really be talking about trusting AI, or should we be using some analogous, like closely related words such as reliability? And this has come up for a long time in the organizational space too. People are always asking, like, should we make attributions the way we do to individuals to organizations? But I think when you go to technology, it gets even more strained. And again, the reason to care about this is just because when we try to put this many things into the discussion about trust, we start to have to juggle like a lot of working definitions about what trust means, and the term starts to kind of empty of meaning, which I worry about.
So let me pick up on that thread. So if you were to refocus us on what is important to know about the level of trust, let's not put a value judgment on the level of trust in the American healthcare system right now, would you go back to the individuals, the people we want to trust to act on our behalf? Or do you think it's actually better at this point to say that trust in individual providers is important, but we have to work on organizational reliability and people's appreciation for organizations choosing the right technology tools and things like that?
I'll give a quick answer to
Yeah.
that also dovetails on the AI.
Yeah.
So one of the things that we did in our work was, after we asked trust questions, we asked an open-ended question in which we said, when you answered all of those, what was going through your mind about trust? How do you define trust? What do you think about trust? And we got some beautiful narratives from people, and we took AI and we used AI to categorize those things. And then we said, what are the categories that are really predictive of trust? And one of the things that really popped out was quality of interactions and personal experiences. And those things are just incredibly predictive of whether or not somebody in our surveys then went on to have broad measures of trust. And so I think those are places that we really want to emphasize. And I think that dovetails with what we were saying earlier about just the complexity of the system. It makes it more difficult to have quality interactions and personal experience that is meaningful.
All of the trust data that I've ever seen related to healthcare suggests that people are much more likely to trust someone physically proximate to them than someone physically distant from them. And as you get to higher levels of abstraction, you ask people about organizations or systems or things like that, people's trust goes down because they just feel like they can't touch it, feel it, smell it, etc. So when I think about a trust building strategy, I think it has to start hyper-locally with individuals, most likely nurses and doctors, who are still, even after COVID, after all the hand-wringing, all the alarmism, like they're still very highly trusted professionals on average. And I think, if I ruled the world and I was able to roll out some great strategy, I would say doctors and nurses, we need you to sort of be knitting people up levels of analysis. Meaning I need you to show up and say, I'm Dr. So-and-so, you've known me for a long time, you trust me. Let me tell you, this clinic or this health system that I participate in, good people run it. I really believe in it. I think that it's doing what's right for you and your family. And only by sort of lending trust up the levels of abstraction do you rebuild trust in those higher levels of abstraction. It's not going to happen because I read something in the newspaper about a new hire at the CDC that makes me think tomorrow I'll trust the CDC a lot more. It's always kind of flowing through those personal interactions. But in some ways, I think this reeks of ickiness to some people because what I just described sounds like a big social engineering effort. But if clinicians were able to be authentic and sincere when they say, I think you are right to put your trust not only in me, but in this organization, in this system, I do think that's the most successful strategy we have.
And I'd be curious to those that study this from an academic standpoint. Is an individual that accesses their health care at a community health center or a rural health clinic, do they trust that facility more than the 800-bed hospital in Washington, D.C.? And it sort of gets back to everything that you've heard. It's about interaction. It's not just about access in that case, but it's about almost a family feel of that particular establishment. And I think, as Michael said, the business model of a lot of healthcare has changed to more the corporate structure. And it's in how you are greeted when you walk in the door. The first thing they ask for is your insurance. The second thing is, has any of your information changed? And then it's go wait in that chair until somebody's ready to come get you. There's not a warm and fuzzy that you have right from the start. What were you going to say?
I was just going to say, and then you can fill out that form again. Yeah.
And if you see somebody that goes to a community health center, it never happens like that. They get the information, but it's after they've gotten to know you to some degree.
Yeah, so I think just the lack of supply of physician labor and the ability of the system to produce more physicians means that they don't have time for the quality interactions. I think that if we had that clinical perspective up here, I think they would say that it's very difficult today when the average interaction is 7 minutes to kind of build those relationships. And getting back to the disparities kind of angle, in Montgomery County where I live, most people have concierge medicine. They pay for access to physician time to build those relationships. And in rural areas, we have a maldistribution problem. We have fewer physicians. We can't incentivize physicians to practice in rural areas. They don't have access, like you said several times. So I think it's the system that we have now. It makes it very difficult to have those interactions, and people who are lower on the SES poll are unable to purchase them via something like concierge medicine.
So I'm older than everybody up here. I see a few in the audience that may be about my age, but the experience of going on to Medicare, the experience of leaving a hill up here for 30 years where I paid because I was here all week to have access to a physician in the Capitol, and all of a sudden return home after 30 years and realize I've got to find a doctor. I don't have one anymore. I got to tell you, this is a terrifying experience to go through. And the big question is, do you get somebody that's old and artful, or do you get somebody that's young and you think they still read the Journal of Medicine? Because I want to make sure they take care of me, keep me well. And I think that the situations that people face community by community, healthcare is the most difficult thing to understand the delivery system as a consumer. And for many people, the delivery point is the emergency room, which is absolutely the worst place to deliver healthcare unless it's trauma. But it is the most expensive place in the entire system. So there's a perverse setup here that I think contributes to the confusion that's out there.
Absolutely. Well, now we're going to get to my favorite part of the panel, which is when the panelists get to ask each other very intelligent questions that I wish I'd thought of. And we are going to start with you, Michael.
Great. I have a question for Lauren. I was really intrigued earlier today when you told me that one of the results from your work is that when you ask people in their local area, are these facilities for-profit or non-profit? Most people dramatically overestimate the extent of for-profit facilities. And I was curious what you think that kind of implies for their behavior and their overall morale about their interactions.
Yeah, so Michael's referring to a paper that I published in Health Affairs Scholar last year, 2023, and we ran this survey and we asked people for their zip code, and then we showed them hospitals in their zip code and we asked them to guess, essentially, do you think this hospital is a for-profit, a public, or a nonprofit? And people dramatically overestimate for-profit healthcare. On average, people think that roughly 60 or 65% of US hospitals are for-profit, when in fact, 65% or so are nonprofit, 20% are public, and the remainder are for-profit. So I don't know if it changes their behavior, but I think it may just be a coping device. Like, people feel a little bit burned by healthcare. They get really big bills that they don't understand. And it certainly has kind of shaken their faith or confidence or whatever they thought a nonprofit or a charity was. They kind of say, well, this surely can't be it. So they sort of resign themselves to it must be a for-profit, and that's almost a way of making peace with the behavior they see from local hospitals. So again, most people I live in New York City. There's a hospital on every corner. Many people don't really have a meaningful choice of hospitals. There might be two technically in their hospital service area, but one is closer, one they know people at, the other they don't. And so, whether it changes their care-seeking behavior is something for you to investigate in a future paper, but I think it's sort of deflection or coping mechanism more than anything.
All right, Lauren, your turn.
Oh, I have a very non-academic question, which was, how did you go about finding a physician when you came onto Medicare?
I think I did what most people end up doing, and that's I talked to my kids. And I said, who do you go and see? And what's your level of satisfaction with them? And I think my son was amazed when he found out that I went to his doctor. Because we tend to go to somebody aligned with our age. And, my experience on the Hill was, we're not the smartest people in the world. Occasionally, you need to look at generations below you to find out the answers to things, because they figure it out a lot quicker. And I think technology is a great example of that. At the end of the day, we don't do a good job of providing information about delivery points in the healthcare system where they're easily accessible to folks. And that's why I stressed earlier transparency, because I think transparency in price is the key to transparency in performance. And we just don't see it to where it could be used as a tool to determine what your delivery point's going to be as a consumer today.
If that information had been available, do you think you would have used it, or do you think you still would have gone where your son suggested?
I think I probably still would have gone where my son led me,
Yeah.
but I think it would have influenced me had the transparency developed something that, whether it was a simple customer satisfaction on that individual. But we don't do it in healthcare.
Yeah.
We do it in restaurants and hotels, and I think we even trust that when we go on an Uber app, an Uber's going to show up.
Yeah.
So there are different levels of trust. Is it my turn?
It's your turn.
So I'm going to go to Michael, because this is more of an economics question. We've seen a huge appetite for private equity to get involved in the healthcare space, and specifically either practices or specialties, some much bigger than others. And I've got to believe that they did it because of the return on investment. So as healthcare profitability contracts, and it will, what's private equity's response to that? And how do you anticipate that will change the healthcare architecture at the time?
Yeah, it's a question that comes up a lot to think about the acquisition of different facilities. I think in the research we see evidence that you have a lot of facilities that are not doing well financially, and they're appealing to private equity because private equity can move in and can do the magic that private equity does in changing the debts that these organizations hold, in changing the workforce practices that they go for, and then they can sell them at a profit. And the extent to which that is good for patients typically seems to be, it's not great. It's not helpful. Because these places are then stretched, and these practices make it such that these kind of personal interactions and all the things we've been talking about are more difficult. It may also align with this kind of increased consolidation. So when they buy a facility, they're planning to sell it at some point in the future. It's not too distantly in the future, actually, and they sell it to a larger organization that kind of gobbles it up because it's now a more attractive piece of property. And so it has the double effect of affecting health in the near term, but also probably affecting prices in the long term because of consolidation. What the solution to this is perhaps for the policy folks to talk about, but I think the evidence is pretty straightforward at this point.
Okay, I knew that was going to be great, and I have to say these questions from the audience are fantastic, and they are very deep questions, so I'm worried about getting through many of them in the time remaining. But I'm going to do my best to synthesize across a few questions. So if you don't hear yours, I'm trying to convey the spirit of it. And also, I think we can stay around, some of us, afterwards in the networking reception to get additional questions in. One that I found interesting that we haven't touched on yet is that there are places that are trusted within the healthcare system. An example that this questioner mentioned was places like the VA in many places, the Kaiser system. And can we learn from these institutions, or what can we learn from these institutions that could help us? Anyone have thoughts about that?
I think the answer is yes, we can learn. And I think the VA has been a case study, at least on Capitol Hill, for quite a while. The one that gets highlighted the most is negotiation on drugs. That's not where they excel. Is they have a very diverse, sick population, and typically the issues that present themselves in a VA facility they're totally different than the rest of society, because they are the result, in many cases, of service, and they deteriorate over time. When you look at the mental health space today, over 50% of the psychiatric providers are owned by the VA.
Did not know that.
And it's because the VA population needs that service greatly, but what that caused was a tremendous shortage on the private sector side of mental health professionals. And I think that's an area that technology is looking at now to see if they can fill a gap that's there that can't be filled with bodies, and you can't generate the workforce.
My quick thought on that is, of course we can learn, but I don't think we're going to learn easy stuff the way we usually talk about, right? Because the VA has a very unique patient population. It also, among the many other things that make it well trusted, enjoys a lot of gender concordance in the kind of care that gets delivered there. You have a lot of male physicians, you have a lot of male patients. We would do very well to try and learn from them about the power of concordance, and that would mean trying to facilitate other kinds of concordance, gender concordance, racial concordance, linguistic concordance. But that's not something you go and you're like, oh, look there, they sit on the bed. We should just train our people to sit on the bed. That's a long-term project. You know, Kaiser salaries its physicians. So these are like structural things that we would learn. It's not kind of gimmicky, like, oh, do a site visit and then we'll get some like little behavioral modifications we can take back and teach our team.
Yeah, and I mean, I think some of the things from Kaiser have been exported, right? But like in terms of accountable care organizations, and you know, the evidence is not overwhelming that these things are effective. So in a broader sense, because of the complexities of, you know, moving outside of these niche systems. So yes, we can learn, but I would agree with the rest.
Yeah. So this questionnaire was sort of breaking down what I thought was one positive path forward that Lauren laid out for us, which is building professionalism at the healthcare professional level. And then if professionals feel that they trust the organizations they're part of and they can transmit that to their patients, that is a path forward. This questioner is pointing out that many health professionals don't trust other health professionals. So how do we deal with that? Does anyone have any thoughts about that really tough question that someone has thrown in here?
This is a classic like intergroup relations problem. Yeah, you know, doctors and nurses don't always get along. They don't like the chaplains. They don't like the social workers. There's some turf. You know, one kind of thing that people are trying to do increasingly, which I think is promising, is do a lot of interprofessional training when students are in school. So I get to have classrooms that are mixed in that way: public health, nursing, med, dentistry, and that can help to sort of develop some relations earlier on. But really, you know, as someone trained in management, I think that's like a bread and butter management problem within organizations, that it's managers' job to kind of facilitate and broker those relationships. I don't think there's some like system snap, this is how you make these groups get along.
Although it's not always the case that managers within healthcare, as in academia, we must say, are necessarily chosen for their management expertise, right? They're often
Fair.
very distinguished professionals. So managerial professionalization is maybe an answer there.
I think from the nurse perspective, just valuing the services that they provide from doctors, feeling like their services that they provide are valued by the physicians is enormously valuable. I mean, there's evidence from the NHS on this actually, where they are willing to pay, a large amount of their salary. They would trade off a lot of their salary, and they don't make a lot there to begin with, but they would trade off a lot of it just to have more validation in the work that they do. So there's this kind of tiered, doctors are above nurses, but I think because nurses do so much with the care and are the most trusted entity in all of healthcare by far, feeling some validation in their work would go a long way.
I think that holds true in surveys of U.S. nurses as well. Not the salary trade-off issues, but the feeling valued, the importance of feeling valued. Here's a question that hasn't really come up, surprisingly, given where we're sitting, which is, meaning DC, not Hopkins. What about politicization and the potential for political alignment to affect these discussions, to dominate medical and health expertise?
Politics involved in healthcare?
No.
Never.
Never.
Politics is alive and well, and it's incredible how quickly, when the purse no longer is unlimited, how policy begins to come back towards reality. And I think we've gone through a long period where the perception was everything was free. I mean, we're still on the campaign trail today on both sides, making promises about if I get elected, here's what I'm going to do, and a lot of it's reference to healthcare. Here's the reality. We spend $2 billion a day of debt in the United States. The national debt is increasing at $1 trillion every 100 days. You're the economist. This not only has been unsustainable, we're reaching a critical point. And I think what you're going to see is you're going to see the reality where politicians have to get back into a reality box of trying to produce policies that match a positive result. And there's nothing tougher than to sit on Capitol Hill and say no to folks. And I can assure you that the medical community is one of the biggest lobbyists in total in the country, much more so than bankers, I will say, Tom, Mike. And it's a very compelling thing. My rule for my staff was, don't ever present me a bill on healthcare that you want me to sponsor unless you can show me the human face behind it. I want to see who's impacted by it, positively and negatively. And I found that to be the most foundational way to approach it, because I understood who was impacted by exactly what we were doing. That doesn't seem to happen today because this is all about promises versus reality.
I mean, I think it speaks to the uniqueness of healthcare too. I mean, I've done a lot of work on direct-acting antivirals for hepatitis C. These came out in the mid-teens, so in 2014. The initial price for a course of treatment was $80,000, but these were curative technologies, right, relative to the past technology. So when the science, the studies came out, the cost effectiveness analyses on these things, they were very cost effective, even though they were $80,000, right? But as technology grows, as technology expands, we're coming up with increasingly these innovations that are so expensive that even if they benefit the person and perhaps even others around them to such an extent, the public system simply can't afford these kind of therapies. And so I think that's where these hard questions come in.
Well, you've opened the door to talk about CBO.
There are friends and colleagues in the audience from CBO, I'm sure.
I think one of the biggest frustrations on Capitol Hill is the inability to get dynamic scoring to recognize savings. And I think it's gotten better, and I can say this now, I'm on the outside. But Michael, I can remember when Senator Coburn from Oklahoma and I went to our colleagues on both sides of the aisle after our experience with PEPFAR, AIDS cocktails in Africa, most successful program, foreign policy program we've ever had, still is today. And we went to our colleagues and said, hey, we need to make sure that every American that's HIV AIDS positive gets a cocktail. We should pay for them. And then the price tag on it was about $14,000 a year. And our selling point was, if we do this, we eliminate 2 hospital visits that year, one for a retinal infection, one for pneumonia. And at that time, the hospital cost was about $34,000. The federal government saved $20,000 for every patient we did this for. We got absolutely no traction to do it. So my point is, it wasn't just CBO that couldn't look at it and say, there's tremendous savings down the road. And the truth is that the new therapies are going to be interventional so early in people's lives because of our ability to detect things that we can reverse before they've ever experienced an impact from it. There can be tremendous savings, and I think this is one of the probably national debates we're going to have about GLP-1 drugs going forward. Yeah, it's expensive today. But as you begin to see the new indications that are coming out of some of the clinical work, if you're really are having an impact on cardiovascular disease, if you're having an impact on this, diabetes alone could have proven it's worthy for us to do. You start putting these other things in the category, and all of a sudden the scale goes heavily in one way.
Right. Lauren, do you have a final word you want to get in?
Oh dear. Trust important. No. No, I mean, you have additional interesting data on political polarization, right, from your work?
Sure, yeah. I mean, you know, we had a nationally representative sample in one of our surveys. You know, we asked about political affiliation. It was the case that Republicans and Democrats had very different levels of trust. Democrats and Republicans both trust nurses enormously, but then when you move to other sectors, Democrats were trusting more of most things, doctors, hospitals, particularly public health agencies. There was a big gap between Democrats and Republicans. Republicans trusted less than independents and those of other affiliation. But then when we did the kind of open-ended qualitative work, and we put the AI on that qualitative work, it just demonstrated that Republicans and Democrats see the issue of trust in very different ways. So when Republicans, when they wrote about COVID-19 policy, huge negatives on trust. When Democrats wrote about COVID-19 policy, big positives. Yeah, I mean, they were just completely opposite reactions. When Republicans wrote about quality interactions, it was the biggest predictor of higher trust. So, you know, in terms of policy that wants to build trust, you know, we have a lot of heterogeneity out there in how people think about these issues. And so there's no silver bullet.
Yeah. Well, I think no silver bullet is probably a great way to end this panel. You've heard a lot of complications here. You've heard a few paths forward. You know, as a loyal former CBO staffer, I have to say, if Congress gives CBO the agenda to project beyond a 10-year window, which is Congress's decision, then no one would be happier than CBO to think about what the long-term effects of these new technologies, of increasing professionalism, of building trust at all levels of systems and organizations, and of doing forward thinking about how, given where we are right now with low levels of trust in many areas, how do we move forward as things become even more expensive, as people become even more distrustful of the healthcare system if they feel that they can't afford things that may change, as the senator put it, the trajectory of their life. So I hope we've convinced you more than that this topic is important, but that there are a few solutions going forward here, a few avenues that we can pursue, both from the policy perspective and then also clearly from the research perspective. And so before we adjourn to the reception, I want to point out that on the back screen, we have QR codes that links you to some of the research performed by our 2 academic panelists. And I'm sure they'd be happy to take questions after we adjourn. So please join me both in thanking all of the HBHI staff who helped to organize this event and the panelists.